morning, friends. Today, our guest speaker is Dr. Gaurav Prakash from PGI Chandigarh. He is going to lecture on late effects of chemotherapeutic agents in hemat-oncology practice. This webinar is brought to you by Mumbai Hemat-oncology Group, supported by NATCO Oncology and managed by Perfect Square. I thank Mr. James Rajakumar and their team from NATCO, Mr. Yash, Mr. Kalpesh and the team from Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest, Dr. Samoon Jilani from Srinagar, our guest speaker, Dr. Gaurav Prakash from Chandigarh, all our discussants who are themselves eminent hematologists or medical oncologists, and you participants for sparing your Sunday morning, afternoon, evening, depending upon which part of the world you belong to. We have over 400 registrations from 27 plus countries today. This is our website, www.mhgindia.com. There is no password. You can visit the website to look at our future academic events. Next weekend on Saturday, 10th December, from 7 p.m. onwards, we have Dr. Renu Saxena speaking to us on what's new in the pathology of acute myeloid neoplasms. And next Sunday, 11th of December, from 11:30 onwards, we have Dr. Shruti Kakkar from Ludhiana speaking to us on emerging complications in thalassemia. To introduce our discussions to you, we have very important persons from all over India, and these are put up alphabetically over here. To briefly introduce them to you, we have Dr. A.K. Ganju from Nagpur, Dr. Abhilasha Sampaga from Belgavi, Dr. Avriti Bawaje from Dehradun, Dr. Chirasri Sanyal from Kolkata, Dr. Darshana Rane from Mumbai, Group Captain Dr. Harshit Khurana from Pune, Dr. Manoj Toshniwal from Aurangabad, Dr. Muralidharan from Mumbai, Dr. Nilesh Vasekar from Nashik, Dr. Nishad Dhakate from Nagpur, Dr. Prakash Kumar Mandal from Kolkata, Dr. Prashant Bhatt from Mangaluru, Dr. Priyanka Srivastava from Karamsep, Gujarat, Dr. Ruchira Misra from Mumbai, Dr. Sandeep Bartakke from Pune, Dr. Shajia Gulshan from Kolkata, Dr. Shura Neil Ball from Kolkata. And now it's time to introduce our special guest of the day. And I'm extremely grateful to our chief guest, Dr. Samoon Jilani, for sparing his valuable time to inaugurate our webinar and bless us. Everyone knows him, but to complete the formalities and introduce him to people who have logged in from outside India and our junior colleagues. He did his MD in internal medicine from Sher-e-Kashmir Institute of Medical Sciences, that is popularly known as SKIMS, Srinagar. Subsequently, he did fellowship in hematology and bone marrow transplantation from the prestigious Christian Medical College Hospital, Vellore. He is ex-professor and HOD, Department of Clinical Hematology at Sher-e-Kashmir Institute of Medical Sciences, Srinagar. He was instrumental in establishing the Department of Clinical Hematology and BMT at SKIMS. This department at present is routinely doing allogenic bone marrow transplants and running DM course in hematology. Presently, Dr. Samoon Jilani is working as a clinical hematologist at Florence Hospital, Srinagar. He is Vice President of JK Hematology Group. He is member of various national and international hematology societies. He has presented many papers in national and international conferences. I request Dr. Samoon Jilani to inaugurate our today's webinar and give some words of wisdom. Thank you. And over to you.
Thank you, sir, for your kind introduction. Good morning. At the outset, I would like to thank Professor M.B. Agarwal, sir, and Mumbai Hematology Group for providing me this opportunity to be amongst you this morning and share my views. I don't think it is possible for many of us sitting here to conduct 2 webinars every week, and they too for many years now. It was started because of COVID, and it is now continuing till date. Sir, you have kept this candle burning and enlightening us with the latest in the field of hematology and hemat-oncology and lab hematology. It is just simply your love for teaching and your desire to keep the young hematologist abreast with the latest in the field. Respected teachers and their colleagues, you will all agree that in the last 2 decades, there has been huge progress in hematology and hemat-oncology and lab hematology, especially in hematology and hemat-oncology, which has made the lives of our patients very comfortable. It has given answers to many of our unresolved issues. It has answered many of our unanswered questions and helped us in crossing the hurdles which we are first facing. We are equipped now with all sorts of transplant. We have many targeted therapies in use, and still there are many in pipeline. And now we are eyeing towards our CAR T-cell therapy. Having said that, let me confess that there are still many questions unanswered, which you will all agree. There are many hurdles yet we have to cross. There are many issues which have to be settled. And because of those unsettled issues, we are still using the terms of palliation while discussing with our patients. I'm sure that this huge challenge can be met if we all work together. And it's only possible if we divert our minds towards research. To become a researcher, one has to be very crazy. Have those crazy ideas, dream about them, chase those ideas with dedication, endurance, and patience, prove it to the world, and then implement on our patients. Ours is a huge nation, not only in terms of area and population. We have very rich culture. We don't have neither dearth of our fertile minds. We have proved it time and again that whenever we have got suitable atmosphere, we have not lagged behind the best in the field of medicine. Not only in the field of medicine, in the field of economics. Now, of course, in the field of politics, we, although are still in the developing country, but our views are being heard, respected, and implemented. This is a huge compliment to us, and we are proud of this nation. Having said that, let me confess that we, being a developing country, have still many issues, especially our financial problems which we are facing. Our huge chunk of budget is siphoned out towards defense. And rightly so, because we are living in a hostile neighborhood. But guarding a healthy nation is far, far better than guarding a sick nation. And that can be only possible if we have the ability to prioritize our health sector, and there can be huge budgetary allocation for research and people encouraged for research. I will request people who have any influence sitting here at the doors of corridors of power to implement those influences so that there is a good budgetary allocation towards health sector. Dear colleagues, I request you all, especially our young scientists, young hematologists, to divert their minds towards research, dream about those ideas, and find the solution of our unresolved issues. And I am sure together we can do it. With these words, I declare today's webinar open. May God bless you all.
Thank you so much, Dr. Samunjilani. That was beautifully crafted speech. you gave messages which had lot of contents, and I'm sure that all the listeners will benefit from it. You have done a wonderful job in preparing the contents, and so many aspects of life, hematology, and our country were a part of it. Thank you so much for being with us.
Thank
You
you.
have always been with us for all the educational activity. I've been very fortunate in being invited to wonderful place, your institute, Srinagar, Kashmir in general, repeatedly, and we've enjoyed our trip to your place and your hospitality. Thank you so much for being with us today.
Thank you, sir.
We move on to the part 2 of this webinar today. And once again, I'll share my screen, and that is our Sunday quiz. So as you know, that the quiz is related to one subject, and today's subject is systemic AL amyloidosis. As usual, we will be giving you 9 statements, out of which one statement is false. You have to pick up that false statement. Each statement has a number, so you have to email the number 1, 2, 3, or 4, or 5, whatever it may be, of that false statement, and email it to mbagarwal1@gmail.com. We will speak out the names of all the correct replies that we get in the order in which we receive, and the first correct reply, that is fastest finger first, will be the winner. Okay, so we now move on to those 9 statements. And these are these 9 statements. At the top, you have the email ID on which you have to send one of these numbers. You are picking up the false statement out of this. 1. A correct and early diagnosis of AL amyloidosis remains an unmet medical need. 2. Alkylating agents, autologous transplant, and bortezomib were 3 welcome giant leaps in the treatment of systemic AL amyloidosis. Daratumumab, number 3, daratumumab, both in relapse setting and for newly diagnosed patients, is the 4th giant leap. 4. Translocation 11-14 accounts for 40% of patients of systemic AL amyloidosis. 5. Deep responses can be achieved in 70% of these patients of AL amyloidosis having T11-14 translocation by using venetoclax-based therapy. 6. Andromeda is the pivotal phase 3 trial comparing daratumumab with VCD. With VCD alone, without DARA, in newly diagnosed systemic AL amyloidosis. Statement number 7. NT-proBNP of more than 8,500 picogram per ml. Presence of 1q21 gate and shorter duration of DARA-based therapy, namely less than 12 cycles, are negative predictors of the outcome in Andromeda trial. Statement number 8. In patients with nephrotic syndrome due to systemic AL amyloidosis, there is urinary loss of daratumumab, compromising the responses. Statement number 9. Daratumumab-based treatment is effective in removing deposited amyloid fibrils from the target organs. So these are the 9 statements. 8 statements are backed by evidence-based research. 1 statement is wrong. That false statement, the number of that, from 1 to 9, whichever it may be, you have to email to mbagarwal1@gmail.com. I'll keep this slide on for a few seconds for you to go through. Okay. So pick up the false statement, email its number to mbagarwal1@gmail.com. Winner is the fastest finger first. We come to the third part of today's webinar, and that is our weekly hematology case. And we have an exciting case for you this week. A 52-year-old woman, Elizaveta, from Ukraine, married to an Indian engineer, moved to India last year. She was seen by us for unprovoked DVT, deep venous thrombosis, affecting proximal veins of left lower limb. Earlier, 2 years ago, she had an episode of DVT affecting right lower limb. There was a history of fatigue for last 2 years. The comorbidities included controlled hypertension, acid peptic disease, and diverticulitis. There was a past history of traumatic fracture of fibula and tonsillectomy. Blood investigation showed hemoglobin of 18.1, hematocrit of 53.8, with normal white cell and the platelet count. Her oxygen saturation was 99%, and the S-erythropoietin level was 32, with a reference range of 2.6 to 18.5. Iron study showed iron deficiency. The bone marrow biopsy showed mild hypercellularity. So summary of this part of the slide is that you have a young woman, age 52, hailing from Ukraine, gets repeated episodes of DVT. Her hemoglobin is high. Her oxygen saturation is normal. Her erythropoietin is high. And bone marrow is mildly hypercellular. Mutational profile showed JAK2 V617F and JAK2 exon 12, both were absent, negative. CALR MPL mutations were negative. Color arterial Doppler for the renal artery showed no stenosis. Whole body PET CT scan showed no evidence of any metabolically active tumor which may be secreting erythropoietin. MRI of the brain showed no vascular malformation or tumor which could be a source of erythropoietin. This made us move to rare investigations. Erythropoietin receptor mutation analysis was negative. What was picked up was homozygous mutation in PON Hippel Lindu, that is VHLG. And this was diagnostic of an entity. She was advised to undergo phlebotomy, avoid iron-containing medicines, and she was put on anticoagulant, the DOAC, using apexaban 5 milligram twice a day, which she has religiously continued, and at present she is asymptomatic with almost near recanalization of a DVT, no post-thrombotic syndrome, and enjoying good life. So the question is, what was the diagnosis in Elizaveta? So this was her look when she presented to us with polycythemic look, with a little reddish hue on the face and the lips. And that was her appearance after phlebotomies when hemoglobin was brought down to normal. So understanding polycythemia is the discussion for the day. And polycythemia is not same as polycythemia vera, as you must have understood from this case. So I rather use the word erythrocytosis when it is not polycythemia vera, but then that's not something which everybody does. So I make a diagnosis of vera, I call it polycythemia vera. The rest of the cases, I call them erythrocytosis. Now this face, even a novice student in medicine can say that this is polycythemic hand. Sometimes you may have to compare it, like the central is the polycythemic and the other two are not polycythemic. Polycythemia vera requires JAK2 gene mutation. That's almost invariably present. And this is WHO 2016 diagnostic criteria to diagnose polycythemia vera. There are three major criteria related to hemoglobin, bone marrow biopsy, and the mutational workup, either JAK2 exon 14 or exon 12. The minor criteria is erythropoietin being below the normal range. You require either all three major criteria or the first two major criteria and the erythropoietin criteria, because there could be 1% of patients who have both these mutations missing. And then this marrow helps you, which is hypercellular, showing trilineage hyperplasia and increased megakaryocytes, which are large. The treatment recommendation for polycythemia vera are now quite straightforward. Your goal is to keep the hematocrit below 45 with phlebotomy, and majority of the patients will be put on low-dose aspirin once or twice a day. If the age is under 60 and there is no thrombotic history, that's a low-risk polycythemia vera. While if there is either history of thrombosis or age above 60, that's a high-risk polycythemia vera. In the low-risk polycythemia vera, if there is inadequate control of microvascular symptoms or there are presence of other risk factors like cardiovascular, diabetes, hypertension, dyslipidemia, or there is leukocytosis, then besides phlebotomy, aspirin is a must. Many would give aspirin to all, even without any one of these factors. In the high-risk polycythemia vera, phlebotomy, aspirin are not enough, and you would add a cytoreductive therapy. In the standard is hydroxyurea. If there is an arterial thrombosis, that patient has to have aspirin. If there is venous thrombosis, that patient has to have anticoagulants. If the patient is intolerant or resistant to hydroxyurea, younger patient will get interferon. Older patients in past got busulfan, and nowadays you give ruxolitinib. So Jakafi or Jakafi, that is ruxolitinib, is the second-line cytoreductive therapy for polycythemia vera. And in the Western world, you have a better interferon called Ropeg interferon, which is to be injected once in 2 weeks. We don't have an access to this, so we have to use PEG interferon once a week. Coming back to our patient, Yelizaveta, what is her diagnosis? Obviously, she is not polycythemia vera. She didn't have JAK2 exon 14 or exon 12 mutation, and her EPO level was high. Is this Chuash polycythemia? What is Chuash? Chuash is this little place in Russia, and that's the flag of Chuash. So what is Chuash polycythemia? Chuash polycythemia is a rare inherited condition. That's the traditional trace of a Chuash woman. Chuash polycythemia is an autosomal recessive disorder. It presents like polycythemia vera. Like polycythemia vera, it is associated with arterial and venous thrombosis. And what you see over here is the craft work of Chuash. However, JAK2 V617F mutation and JAK2 exon 12 mutation are both absent. Unlike polycythemia vera, the EPO levels are high. All other causes of polycythemia secondary to increased EPO are absent. Oxygen saturation is normal. There is no underlying EPO producing tumor, and there is no renal artery stenosis. And hemoglobin has normal oxygen affinity. So if you fulfill this, this could be a diagnosis of exclusion. However, there is a positive way to diagnose this, as we did in our patient. This entity is due to a specific mutation in the VHL von Hippel-Lindau gene, a gene which is situated on chromosome 3 short arm at the location 25. This results in the substitution of R with W at the site 200. This leads to increased levels of HIF1 and HIF2, HIF standing for hypoxia-inducible factor. This results in hypoxic response even when person's oxygen saturation is normal. This leads to increased production of EPO, which leads to increased production of red cell, and hence you get polycythemia. In other words, Chouache polycythemia, the patient responds to normal oxygen level as if he is in hypoxic environment, and therefore ends up producing more red cell due to this mutation with which he is born, and that is autosomal recessive. Now, there are certain unexplained associated features of Chouache polycythemia. Unlike polycythemia vera, these patients have a very high incidence of pulmonary hypertension. There is a higher incidence of intracranial and other major hemorrhagic episodes which remain unexplained. These patients can have vertebral and hepatic hemangiomas. They develop varicosity of veins. They have abnormal glucose metabolism, as a result of which their blood sugars are low and their HbA1c is low. Their blood pressure is on the lower side. They have elevated levels of VEGF, vascular endothelial growth factor. And lastly, they succumb due to cerebrovascular events or peripheral thrombi right from the age of 25 onwards. Chouache polycythemia was first recognized in the year 1970, that is almost half a century ago, by a Russian female hematologist, Lydia Andreevna Polyakova. She found out this condition and recognized that this is different from polycythemia vera, and also noticed its inherited component. When she picked up 100 people in the Chouache Republic of Russian Federation having this disorder. Though this condition is endemic to Chouache population, the mutation has been noted worldwide, and it has originated from an ancient event. Chouache polycythemia patients in Afghanistan and in southern India share a common VHL gene haplotype. As these patients enter adulthood, the mortality keeps occurring. The mortality curve diverges at the age of 25, that is very young people. A study found that only 30% of patients with Chouache polycythemia survived by the age of 65, as against 60% of the normal individuals born in the same place. There is no proven effective therapy for Chouache polycythemia to reduce their symptoms, complications, or mortality. Individuals diagnosed with this disease do not necessarily need to be treated with phlebotomy or chemotherapy, and no one has shown that these have been beneficial in reducing their symptoms, complications, or mortality. In fact, phlebotomies have led to severe fatigue due to iron deficiency. The standard clinical phenotype in VHL syndrome, characterized by spinocerebellar hemangioblastomas, renal cancers, and pheochromocytomas, are not present in patients of Chouache polycythemia, suggesting that overexpression of HIF1 alpha and VEGF are not actually sufficient to produce tumorigenesis. My last two slides are very important for the postgraduate students in understanding JAK2 unmutated erythrocytosis. So whenever you have this polycythemia or erythrocytosis and the JAK2 is not mutated, both exon 12 and exon 14, then you look at whether there is a long-standing history or there is a family history, versus it's an acquired and it's of unknown duration. So if there is a family history or there is a very long history of polycythemia, then you look at the EPO level. And if the EPO level is low, like happens in polycythemia vera, but because JAK2, etc. is negative, consider EPO receptor mutation, what is called EPO-R mutation. In rest all the conditions, the EPO levels are either normal or increased. So you look at the oxygen tension at which the hemoglobin is 50% saturated. what is called P50, the venous blood sample P50. If it is normal, then consider VHL mutation or CHOASH polycythemia, where EPO is increased, HIF2A, where EPO is increased, PHD2, where EPO is normal, and EPO itself, where EPO is increased. Apparent polycythemia can occur in people who may be on the side of sort of extreme normal population, or finally we call it idiopathic erythrocytosis because we didn't find a cause. If the venous P53 shows you that there is a left shift, then there could be a high oxygen affinity hemoglobin variant, like hemoglobin CISA peaking, or there could be deficiency of 2,3 BPG, or there could be methemoglobinemia. And lastly, on this side, if EPO levels are normal or increased, you may have cardiovascular disease, sleep apnea, Pickwickian syndrome, high altitude, carbon monoxide poisoning, smoking, drugs like anabolic steroid, blood transfusion, EPO doping, contracted volume like dehydration, capillary leak syndrome, diuretics, or gay smoke syndrome. On the other side, EPO levels will be always high. Then think of in conditions which are characterized by EPO producing tumors like renal cell cancer, hepatocellular cancer, cerebral hemangioblastoma, meningioma, pheochromocytoma, uterine fibroids, parathyroid adenoma or carcinoma, renal artery stenosis, polycystic kidney disease, post-transplant erythrocytosis, and what is called TEMPI, where VEGF is normal and is characterized by telangiectasia, erythrocytosis with increased EPO, monoclonal gammopathy, peripheral fluid collection, and intrapulmonary shunting. When you have JAK2 unmutated erythrocytosis, just keep this picture in your cell phone and use this for every patient. In 15 days' time, you can sort out the diagnosis. And lastly, the treatment of JAK2 unmutated erythrocytosis. So first you look whether there is a symptomatology or not. And second thing, you look at whether there is a history of thrombosis or not. If none are there, then there is no evidence that prophylactic phlebotomy helps. So avoid phlebotomy in the presence of physiological erythrocytosis or cardiopulmonary disease. Consider low-dose aspirin daily in the presence of cardiovascular risk factor or CHOASH polycythemia. Consider stopping tobacco. Consider overnight CPAP for sleep apnea. Reevaluate the need for anabolic steroids or withdraw them. Consider ACE inhibitors for post-transplant erythrocytosis. If either there are symptomatology due to high hematocrit or there is a presence of thrombotic history, then you have these two. So for the thrombotic history, consider aspirin twice a day for the arterial thrombi, anticoagulation for the venous thrombi. Consider steps listed above for the asymptomatic cases, and cytoreductive therapy not recommended. While if you've got symptoms without thrombosis like fatigue, tinnitus, headache, dizziness, paresthesia, mental slowing, visual changes, atypical chest pain, dyspnea, palpitation, then phlebotomy only if it results in improvement of symptoms. Consider steps listed above for the asymptomatic cases, and cytoreductive therapy otherwise is not recommended. So I think these two slides on your desktop can be of extreme value in diagnosing and treating JAK2 unmutated erythrocytosis, including CHOASH. One more slide for you. This is the timeline of discovery in relation to erythrocytosis. EPO purification 1977, EPO isolated and cloned 1985, HIF as EPO regulator 1992, EPO-R mutation 1993, VHL mutation, our patient 1997, HIF regulation by PhD 2001, JAK2 V617F mutation detected 2005, a major triumph of medicine, PHD2 mutation 2006. Those 5% of patients having JAK2 exon 12 mutation in polycythemia vera 2007. HIF2A mutation 2008. LNK SH2B3 mutation 2010 and EPO mutation 2018. And now the last part and the most important part of our webinar for the day, the guest lecture by Dr. Gaurav Prakash. It's my pleasure to introduce my friend and colleague, Dr. Gaurav Prakash. Once again, this country does not require his introduction. He's MD Medicine, DM Medical Oncology, Professor, Department of Clinical Hematology and Medical Oncology from PGI Institute, Postgraduate Institute of Medical Education Research, that is PGI MER, Chandigarh. He did his internal medicine from PGI itself. This was followed by DM in medical oncology from AIIMS Delhi. He then did observership in BMT from Cleveland Clinics, Ohio, USA, 2015. BMT in immunodeficiency disorders from Children's Hospital, Los Angeles, USA, 2015. And medical oncology from Georgetown Hospital, Washington, USA, 2012. He's a recipient of IDEA Award by American Society of Clinical Oncology, 2012. He has received various awards and distinctions during his academic career. He's a member of various distinguished hematology and medical oncology societies and associations. He has published peer-reviewed articles in various national and international journals of repute. In addition, he has also written chapters in various books and monographs. He's participated in international conferences and presented oral and poster papers. Today, he's going to lecture on late effects of chemotherapeutic agents in hemat-oncology practice. Over to you, Dr. Khan.
Thank you very much, sir, for the kind introduction. And yeah, so just to confirm, I think my slides are visible now.
Yes.
Right, sir. A very good morning, everyone. Honorable Dr. Agarwal, Dr. Professor Jilani, and other esteemed faculty members who are part of this webinar. I'm really glad and delighted to discuss this topic, which is close to my heart and I'm sure for everyone's heart also. I think it is important before we dive deep into the topic to have a look why this topic is so important. I'm going to present to you this data, which is taken from SEER database and is a US data from National Cancer Institute. It is easily accessible to all of us. Now, this table is going to show the 5-year survival of common hematologic malignancies. I would like to state it here that this is non-selective, neither selective for age or subtype of lymphoma, leukemia, and myeloma. These are the 3 major types of hematological malignancies we deal with on day-to-day basis. And the data, SEER data says that the 5-year survival for collective lymphoma subset is around 71%. For leukemia, it is nearly 60%, and for myeloma, 45%. So we can very safely say that more than 50% of our patients are likely to survive for 5 years or longer. So therefore, there is a clear subset which is emerging, which will need some more care beyond standard anti-cancer therapy. And now this is being talked as something called silver tsunami. Now, this is from the US data where we know the aging population, the demography of the country population is different. They have more people in the silver years than the younger. So I feel that in our country, apart from silver tsunami, we are going to have a relatively younger tsunami. All the seniors would agree that there is published demographic data that the incidence of cancer in Indian or developing countries is maybe 1 to 2 decades earlier. So therefore, the kind of population that we are going to treat on long-term basis is likely to be much younger, and it is going to have a silver as well as young tsunami in developing countries like ours, India. Now, this is an interesting term. The term silver tsunami was first used by geriatricians. And they say that there is going to be a tremendous requirement of healthcare staff and the infrastructure to manage issues related to people in silver years. Of late recently, because of the survivorship issue, the oncologist hematologist team have adopted this term with respect to cancer care. And there is a recent article in 2020, and they wrote very beautifully on anticipating the silver tsunami, prevalence, trajectories, and comorbidity burden among older cancer survival in the US. In this paper, a very elegant graph is shown, which I'm going to share with you. Now, this shows trajectory of cancer survivor according to the age group over a span of last 50 years nearby, starting from 1975 and giving a projection up to 2040. So if you see, in the beginning, when the SEER work started, the survivorship data showed around 3.6 million cancer survivor across all age group. And nearby, we might be here. So they gave data of 2016. There is almost 5 times multiplication of cancer survivor. And this is going to increase in the years to come. That is the projection. Now, if we see in the age group, this is in the US, that 85 plus, the group of people will be 5 million survivor. In 75 to 84, 10 million, and even younger if you take. So these are the silver years, like 15 millions. Now, if you combine all of these figures together, it will be close to 30 millions. 30 million is a whooping number, and it is actually equal to 2 Australia combined. So this kind of burden is in the US, which has 1/3 of the population of what we have in our country. So the projection can be unimaginable, because now luckily we have access to most of the drugs. Our healthcare infrastructure is improving, so the outcomes are going to improve. There is no doubt. So with this kind of projection in the US, we are going to have a huge task at our hand to handle this population, which has been treated and cured from their cancers. So that brings me to the young tsunami that we are likely to see. I will make a statement that we are unprepared as of today, and I'll tell you why. The reason is in our training, in our discussion, in our research, it has always been disease-centric. Even the Time magazine write how to cure cancer. I think when we talk of late effect survivorship, we have to have a slightly semantic variation of this statement. And rather than speaking on how to cure cancer, we should be saying how to cure a patient from cancer and its after effects. Now, if you focus on this aspect, the focus will be on what drugs are there, what new drugs can be given, how to reduce the size, tumor burden. But when you talk of curing a patient, we become patient-centric. So apart from drug and the treatment and the disease, we also need to see what is happening to the patient. So therefore, this kind of shift is needed in our approach when we can say that we are getting prepared to handle this upcoming tsunami, which is going to come whether we prepare for it or not. So taking this statement forward, how to cure a patient from cancer and its after effects, I bring in the concept of cancer survivorship. Cancer survivorship is rapidly being recognized by majority of the bodies which are involved in cancer care, especially in the Western developed part of world. And it has 3 major components. The first one is the physical health needs of a patient or a survivor, management of sequelae of various kinds of anti-cancer treatment. The second aspect is psychosocial health needs. And the third aspect is, which is a part of holistic healthcare, is financial as well as vocational needs. All 3 of them are equally important, but as our domain of expertise lies in this part of management, the remaining seminar is going to be focusing on this aspect only, and we may have experts from respective fields to talk about the others. Now, before I discuss about individual organ-specific survivorship and late effects, I'm going to show you data that survivorship care works. The impact of survivorship, especially with focus on hemat-oncology. Now I will show you 2 graphs, one for patient survivors of leukemia, other for non-Hodgkin's lymphoma. And these are survivors, AYA, adolescent and young adult survivors who successfully defeated their cancer. This is going to show you the all-cause mortality over a period of last 30-40 years. So this is the graph over here. And so the top one is 1975 or 80, then 85, 90, reduced from 28% to only 5%. For non-Hodgkin lymphoma, the reduction in mortality has come down from 13% to 3%, barely 2 to 3%. So this is the testimony of the fact that apart from defeating cancer, we need to do much more for these patients to reduce their risk of dying from the causes other than cancer, which is a part of all-cause mortality. So I think with this introduction, I am going to open up the topic, late effect of chemotherapeutic agents in hemat-oncology practice. There is a definition which I would like to share. we generally talk of late effect, but semantically, there are two very closely related terms over here. Number one is late effects. The other is long-term effects. Now, what is the difference between the two? The long-term effects are defined. The side effects which started at the time of giving anti-cancer therapy and they extended beyond the completion of therapy. Very subtle difference. The late effects are the one which occurred due to the therapy, but they started after the treatment ends, which may be many months to years to maybe decades. Let us see a few examples. Now, long-term effect is like cardiac injury happens during when you infuse chemotherapy. Patients subsequently develop CHF, they have vascular injury, hypertension. We all know issues related to gonadal, fertility, and psychosexual dysfunction. Cognitive decline, neuropathy are few of the examples of long-term effects. On the other hand, late effects are like injury to the bone marrow niche, dysplasia, other secondary neoplasms, and then osteopenia, osteoporosis, leading to increased risk of fracture. Now, we should not fret too much about the definition because there are many things. For example, cognitive decline may not be there. It may become apparent after 20 years, so it can very well be here. But then we need to understand that the difference, the definition. These are accepted definition of two terms, late effect as well as long-term effects. Now, my scheme of presentation is going to be, I'm going to focus on 5 top most important one in interest of time. Number 1, cardiac effects, endocrine effects, skeletal effects, brain-related issues, and second, primary neoplasm. So moving on, starting with the adverse cardiac effects of various kinds of anti-cancer therapies. This is very interesting. I think, all of us keep thinking about on a daily basis whenever we treat a patient with potentially cardiotoxic drugs. In the literature, 3 types of cardiotoxicities are defined: type 1, type 2, and type 3. Type 1 cardiotoxicity is what conventionally the common garden variety of cardiotoxicity that we all know. Whenever we use anthracyclines for various hematological malignancies or solid tumor, we know that it causes cardiomyopathy, it kills the myocyte, and all of us are aware of it. The mechanism is myocardial cell death. It is also equally important to understand other types, type 2 and type 3. Now, first I will take type 3. Type 3 is caused by myocarditis. And we know the drug, the conventional drug which causes myocarditis, myopericarditis, is cyclophosphamide. Now, with increasing use of haplotransplant where we are using PTCY in fairly high doses, myocarditis is going to be an issue that we again are likely to see. Of late, we were not using as high doses of cyclophosphamide. The second agent is immune checkpoint inhibitors. Left and right, especially those who also treat solid tumors, they know checkpoint inhibitors have made inroads. Although their efficacy can be questionable in every sphere, but then they are being used. So they cause myocarditis because of inflammatory cell, which is T cell in this case, infiltration into the myocardium. Now, apart from these 2 very distinct and well-defined cardiotoxicity mechanisms, everything else which can affect the heart is clubbed into type 2 cardiomyopathy. So these are the 3 types of cardiomyopathy which are therapy-related cardiotoxicities. I'm going to show them in a pictorial way in the next slide. So this is cardiotoxicity of conventional agent. And as I told you, the traditional conventional cardiomyopathy is over here. And everything else, any chemotherapy drug or treatment which can produce arrhythmia, which can have an atherosclerotic dysfunction like endothelial dysfunction or accelerated atherosclerosis can produce this. Any DVT, Professor Agarwal showed an excellent case of DVT, although it was not therapy related. Pulmonary hypertension, we know dasatinib is up here. Systemic hypertension, cisplatin causes it. Pericardial and valvular disease. So all of these are actually type 2, produce type 2 kind of cardiomyopathy, and type 1 is the conventional one. Now let us see the drugs. Now, if you see all of these drugs, they are by and large used in hematology, hemat-oncology, anthracyclines. We use alkylating agents, both of them, antimetabolite mainly cytarabine. We use cisplatin, bleomycin, and thalidomide. And you can see they have various mechanisms. The important one being cardiomyopathy, which is seen with anthracycline, which is a prototype of this kind of cardiotoxicity. Alkylating agent, all of them are cardiotoxic, especially these 2. Cytarabine, apart from being cardiotoxic directly, it also produces pericardial. We all know pericarditis. Our teachers have taught us to always auscultate heart in a patient of AML when the patient is on high-dec therapy because of this reason. And bleomycin, we all understand. Peculiar side effect is pulmonary hypertension, which can ultimately have a right heart failure. So we need to keep in mind that it is not a single mechanism which is playing every time. There can be various types of involvement or mechanism which can affect the heart in a patient who is being treated for a cancer. Moving from conventional drugs to targeted therapies. And targeted therapies, again, we have a plethora of long list of drugs. I have highlighted for you hematology drugs with an arrow. So you can see our proteasome inhibitors, they can have direct cardiomyopathy as well as hypertension. mTOR inhibitor, the use is going to increase in the times to come, especially with indolent lymphoma. And they have multiple mechanisms, like they can produce arrhythmia, myopathy, and many more. And our talk of the town, the most famous drugs that we use, hemat-oncology, is BCR-ABL inhibitor, TKI, ibrutinib, acalabrutinib. So they have a strong, especially nilotinib here, a strong arrhythmia potential, which can have cardiotoxicity. And apart from that, dasatinib has pulmonary hypertension, thrombosis risk, and atrial vascular disease. So meaning I want to reiterate is that cardiotoxicity, always, whenever you see, now time has come that we have to just stop thinking about cardiomyopathy, which is a common garden variety. We have to keep other points in time because the newer agents are having variable kind of toxicity. The last and most important one is our latest kid on the block, immune checkpoint inhibitor and CAR T cell therapy. Both are being done in our country, India, and they can produce almost all types of cardiotoxicity, except maybe valvular disease and systemic hypertension. And as I told you, they produce type 3 kind of cardiotoxicity, which is inflammation because of direct infiltration of T lymphocytes. So I think in the years to come, we are going to see more of these therapies. So therefore, we have to be number one, aware of the existence of cardiotoxicity they produce, as well as look for them whenever the patient comes for follow-up. Now, after introducing the topic, let us talk of anthracycline, which is the prototype for cardiotoxicity. We all know there are two types of cardiotoxicity of anthracycline. One is dose-dependent, and the second is idiosyncratic. Now, idiosyncratic, as the name suggests, is something which can happen even with the first dose. Nobody can predict it. If we cannot predict it, we cannot prevent it. The manifestation is mostly arrhythmia or flash pulmonary edema because of failure. Thankfully, it is very, very rare. What we are going to talk about is dose-dependent cardiotoxicity. And this is the graph, this is the table which shows the incidence of CHF. So you can see from 150, 300 to 450, the incidence of CHF is just around 3%. Although 3%, it is not written anywhere, but we all will agree that 3 to 5% severe toxicity is something which the whole field of cancer doctors have accepted. Okay, this kind of severe toxicity is acceptable to us so long as the drug is effective and treating a patient. But if any grade 3-4 toxicity moves beyond 3 to 5%, we become uncomfortable. So therefore, you can see the moment you increase the dose of anthracycline from 450 to 600, there is almost 3 times tripling of the risk of CHF. So therefore, it is a no-go situation for all of us. And we all have been strictly trained to cap it at 450, 500, maximum 540. So this is a table for that. And the mechanism, as most of us are practicing hematologists and oncologists, we know it is the reactive oxygen species, which is iron species, which leads to destruction of all kind of cardiocytes. For example, cardiac smooth muscles, they die. It affects the cardiac progenitor, so new myocytes are not produced. It affects the endothelial cell, so vascular dysfunction is there. It affects the fibroblast because of the cardiac stroma, as well as the conduction system gets affected. So therefore, doxorubicin is a pan-cardiac toxin or inhibitor, should I say. Because of this, what happens? Toxicity will happen whenever you are going to use anthracycline. It will produce toxicity. That we cannot stop. What we can stop, we can look for mechanism to reduce its effect. Two very simple things is prolonged infusion rate can reduce the peak level of anthracycline, and therefore it may reduce cardiotoxicity. All of us can immediately adopt it if we can. The other is use of liposomal doxorubicin. Now, when this drug came, it came with fanfare. It was, put forth by like, this is going to be the drug because no cardiotoxicity. However, it could not live up to the promise made. Cardiotoxicity is there, but definitely the incidence is lower. The second issue is the cost, because if you see the cost of simple doxorubicin is very, very inexpensive, but liposomal formulations are always expensive. So this can be a good option, but not for a large subset of population. formulation. My focus will be prophylactic drugs. Now, this is a very important table. I really like it. And please, I would like to draw your attention to 4 different phases of cardiotoxicity. The first is at the beginning of therapy, which is primary prevention. The second is potential drug within few days or weeks of giving cardiotoxic therapy when there may be some injury. Then after months of therapy, and then years to decades. So these are 4 phases of cardiotoxicity. Now, if you have a look at the beginning, what we can do, we can reduce the cardiovascular factor like we can control hypertension, diabetes better. We can limit anthracycline dose, simple. We can use anthracycline analogs or a liposomal formulation. So these we have already discussed. Now, the next point is dexrazoxane, which is the only approved chelator of these reactive oxygen species. We are going to hear more about it. And then our, all-time cardiology friends, beta blocker, ACE inhibitors, and statins, these are there, and we are going to see what evidence exists regarding their use for cardiotoxicity in cancer patients. Now, this is at the beginning. What happens if you have given chemotherapy? So if we are doing some research, and we are doing troponin tracking. So if there is increment in troponin, it is indicative of myocardial injury. There is some evidence that you can start ACE inhibitor in enalapril. Also, if the myocardial injury is more, then this is a special function of echo. Now, most good cardiology echo machine, they give global length shortening. And if it is there, it is an early indicator of LV dysfunction. So you can probably add a beta blocker. It is with a question mark because there are many ifs and buts. Our cardiologists will be better in guiding us. Now, after months, what happens? The heart has tremendous ability for overcompensation. It compensates. So the patient has completed, cancer is gone. There is injury, but the heart has compensated. So these patients will have only asymptomatic reduction of LV ejection fraction. So in this patient, probably we can use these drugs for longer duration for their secondary prevention. And lastly, if there is an overt CHF, then it has to be managed by like any other CHF, treatment of symptomatic CHF. So this gives a whole journey of a patient who receives anthracycline and who goes on to develop a cardiotoxicity. And these are the drugs which probably can be used at various stages to reduce the impact of this cardiotoxicity. Now, first I will take dexrazoxane, which is always a fascinating drug. Now, this is the only approved drug currently. And it, as I told you, it is going to chelate the reactive oxygen species. It is a derivative of EDTA, and this is the structure of a drug, and it reduces formation of superoxide radicals, which is the toxin. Now, the question comes, if we decide to use dexrazoxane, when to start? So the European recommendation is, whenever the cumulative dose of doxo or daunorubicin is more than 300 per meter square body weight of patient, or epirubicin is more than 600, the recommendation you may start. Now, if we decide to start, the next question will be how to give it. So the dose of dexrazoxane is 10 times the dose of doxorubicin or daunorubicin. You just multiply the patient's dose by 10. It has to be given with a short 15-minute IV infusion. We have to administer just before anthracycline, and after infusing within 30 minutes, you have to start your chemotherapy for it to have the maximum effect. Now, the issue is availability in India. You have to import it. I'm not sure, other seniors can guide me if it is now marketed also. The cost is 1 mg of dexrazoxane is close to $1. So that means if for a say RCHOP patient, you are using 80 mg of doxo, the cost of dexrazoxane is going to be around 65,000. So this is an issue. So therefore, availability as well as affordability remain 2 major issues with the use of this agent, although this is an approved agent to reduce the risk of cardiotoxicity. So this brings me to this very interesting part of the group of drugs, which is beta blocker, ACE inhibitor. Most of us who are trained in internal medicine, we are very much comfortable in using these drugs. We have used it for years. And the second part is that these drugs are easily accessible. They are quite affordable in India. Now we have generic ACE inhibitors and all antihypertensives. So these two are, tick points that we should be looking more, and there should be more research in our country regarding use of these agents, which are available, easy and cheap. So let us see data. please, I would like to only draw your attention on these highlighted slides, highlighted trials. These are randomized trial in hematology patient. Other are mainly breast cancer patient. So like in this first trial, which is ARB, valsartan, after giving this drug, after anthracycline, they noted that there was no elevation of LV diastolic dysfunction, B natriuretic and atrial natriuretic peptide, and no elevation of QTC. Although this is not cardiotoxicity, they are the surrogate markers, but this is one study. Second, which is a very nice study actually, 90 patients randomized to receive 6 months therapy in enalapril and carvedilol, beta blocker and ACE inhibitor. And what they found that there was no reduction in ejection fraction, death rate reduced, and heart failure rate reduced. I think we need to, this is just to show, we need to go deeper into this paper individually and try to see the methodology and what were the merits and demerits. And lastly, again, a hematological patient, in this, they use atorvastatin and they found that there was no reduction in ejection fraction. So therefore, there is evidence that these drugs are working in randomized data also. Now I'll show you data with enalapril, which is ACE inhibitor. Again, this is in patients who are receiving these cardiotoxic therapy. So if you see, if the patient received placebo, the incidence of LV dysfunction was 43, and none of the patient in this trial with ACE inhibitor developed this. We see cardiac events, again 52% versus only 2%. So there is a clear, remarkable benefit which is emerging. Now, all of you, like myself, would be thinking that why are not we using these agents frequently, almost in every patient? I mean, this is a genuine question, which I would like to generate a discussion after the presentation is over. Something, because data is there, randomized data is there. And when I looked into the literature, these 4 points were mentioned why we are not using these agents very actively. And this is from a Western perspective. They say high number needed to treat to prevent one event. So because cardiotoxicity incidence is around 5 to 8%, so large number of patients need to undergo this therapy. High cost benefit ratio, for example, with dexazoxane, or maybe with the ACE inhibitor and all in the US and Europe, they are very costly. More regular monitoring is needed, and patients are exposed to adverse event of these prophylactic agents as an additional drug. So these are in literature, people talk about these 4 points, why these strategies are not very frequently being used for cardiotoxicity. So with this, I think second point, so this is a overall for regarding cardiotoxicity. Now we move on to our second topic, which is endocrine toxicity. This is a remarkable cartoon slide, and this is a gradient of blue color. So blue, darkest blue is the organ which are highly susceptible to therapy, and the light blue is rarely affected. And if you see, thankfully, most of the dark blue is in radiotherapy group. So the endocrine toxicity is mainly with radiotherapy, and the most susceptible one are hypothalamic pituitary, thyroid, and gonads, including adrenal and pancreas. Thankfully, with chemotherapy, which is our topic today, the dark blue is limited to gonads only, and all other organs are light blue. So therefore, the main endocrine adverse event are likely to be seen in patients who have received radiation, but gonadal dysfunction is going to be an issue, especially with chemotherapy alone. These are the 3 different kinds of endocrine dysfunction. Number 1 is hypothalamic pituitary axis dysfunction. And this is mainly seen in only those patients who have undergone radiation or surgery of the CNS tumor, which has led to either severance of the hypothalamic pituitary axis or radiation dose. Typically, if the RT dose is more than 18, there can be issue with hypothalamic pituitary axis. That brings an angle from hematology here, because if we remember, the previous ALL PCI dose used to be 24 gray. I think if we go back just by 10 to 15 years, it used to be 24 to 20 gray. So therefore, that subset of population might experience this effect. And whenever it happens, it leads to global endocrine decline, because pituitary hormone is the master gland, and it's going to lead to almost hypofunction of gonad, of thyroid, of adrenals, of gonads, everything. The second and more important for us as far as the chemotherapy is concerned is the alkylating agent, which we very actively use in patient for lymphoma, BMT, and acute leukemia. So gonadal dysfunction is going to be main talk of today's discussion. And other, like, for example, somebody received TBI or abdominal radiation, then thyroid, adrenal, pancreas are also exposed. And patient who receive prolonged steroid, which is quite common in hematology practice. So hypoadrenalism can be seen. So this is the spectrum of endocrine dysfunction. Our focus will be on gonadal dysfunction mainly. Now we have like male, female, testis and ovary. There are two functions of gonads. Number one is gametogenesis. Number two is hormone synthesis, and they have different susceptibility. If you see gametogenesis, it is produced mainly by germ cells, and in testis, it is supported by Sertoli cells. Clear function, well defined. On the other hand, hormone synthesis is done in testis by Leydig cell, and in ovary, it is done by granulosa cells. So we have two different sets of cells which do this function. And of these two functions, gametogenesis is far more susceptible to either chemo or radiotherapy in comparison to hormone synthesis. Now, what happens, like if you see chemotherapy, just read the name: cyclophosphamide, ifosfamide, procarbazine, busulfan, melphalan, cisplatin. All of these drugs are used in hemat-oncology very, very frequently. And radiation doses as low as 10 gray may lead to permanent dysfunction of gametogenesis. Thankfully, hormone synthesis is more resilient. The dose to the gonads when it is more than 20 gray, then it leads to the hormone synthesis dysfunction. And chemotherapy alone rarely produce Leydig cell dysfunction. So therefore, in male, you have seen the issues with chemotherapy alone are not much. But in women, I think granulosa cell production is much more dependent on chemotherapy also. So this is the overall understanding as far as the gonadal function is concerned. This is just for reading reference only, that cyclophosphamide, whenever the dose is more than 100 mg, permanent azoospermia. Chlorambucil more than 400. Nobody uses this now at this level, azoospermia. Cisplatin again more than 400. So permanent fertility. So these are the agents with high, medium, and low risk. Thankfully for our kids that we treat, vinca alkaloid, prednisolone, and mercaptopurine, they are in low risk of gonadal toxicity. Now, when to suspect in a patient whom you are treating and following for over a long period of time? The answer is, for gametogenesis dysfunction, it is very simple. They will come to you with issues of fertility. And whenever it is infertility, you are dealing with some issues with gametogenesis. For hormones, we know early signs, all of us. For male, they will present with either decreased libido, erectile dysfunction. Many of the people, most of us as Indian, as a society, we are conservative. They may not come, but then unexplained loss of muscle mass can be something which should make us think about a loss of testosterone production. In women, secondary amenorrhea is very common and it can be picked up very easily. Decreased libido, and then appearance of menopausal symptoms, especially if at the time of treatment patient was perimenopausal. They may report to you only hot flashes and issues, rashes, something like that, and there may be these can be the pointer towards involvement of hormonal synthesis. Now, question comes in survivorship of cancer patient: how to screen for gonadal dysfunction? The answer is here. For male, I think if fertility or marriage is an issue, go for a simple sperm analysis that will give you answer. Hormone level, for male, we have LH and testosterone, and we also have inhibin. For women, we know women hormone milieu is slightly more complex. We have LH, FSH, estradiol, inhibin, anti-Mullerian hormone, and progesterone in the luteal phase. So I think since it is not our domain, whenever we are having a patient who is having menstrual dysfunction as well as other issues of gonadal dysfunction, we have to send the patient to a gynecologist for detailed interpretation of these results and to get the patient right treatment. We have luckily both male hormone and feminine hormone replacement therapy available, but I think we should stay away from using them, and it should be done by the respective urologist and gynecologist. Our role is in having a look, can we prevent gonadal dysfunction? If yes, then how? So we have clear strategy for radiation. For radiation, which is the most gonadotoxic, in women, we have a pelvic shield. For male, this used to be an old-time device, which is ball is made up of lead, and they used to just put testis inside before and used to strap it around the patient and give the therapy. This is almost like a Y-field radiotherapy for old Hodgkin lymphoma. But luckily now we have modern machine like IGRT, which is image guided, or IMRT, in which proper planning, 3D planning can be done, which can significantly reduce the radiation to the gonads given. So this is one strategy. But since we are from medical side, are there any drugs? So answer is yes. A lot of research has gone into the role of GnRH agonist. We know they are the agonist hormone, which is secreted from the hypothalamus to the 3. Now, this is a paper on ovarian protection with these agents in various types of cancers. Now, the mechanism is very simple. If you use this agonist, it is going to reduce apoptosis, meaning thereby death of ovarian cell, and it will promote germ cells. So this is a direct effect on ovarian prevention. The second is by suppressing this feedback loop, it brings ovary in a quiescent phase. So when the ovarian follicles are not dividing, they are less prone to chemotherapy after effect. So therefore, by these two direct and indirect mechanism, there is a biological scientific plausibility of using these agents to prevent fertility and gonadal function in patients who are receiving chemotherapy. This is how it is provided. It is an implant. And this is the preloaded implant syringe, which is a very wide needle, and it is given subcutaneously. The dose is 3.6 mg if you want to repeat every monthly. And if the patient you start with 3.6 mg, give it. If the patient tolerates well, then you can give 10.8 mg, which will be effective for 3 months. Those people who treat prostate cancer, they use it very, very regularly. It is easily available and it can be given. We have other alternatives in India by the name of leuprolide, triptorelin. They are easily available thanks to prostate cancer, because they are the frontline treatment for prostate cancer. So they can be used. But before I advocate their use universally, let us have a look at the data. Now, this data is I'm showing from a well-conducted randomized controlled trial, but this is for breast cancer. You see, all the patients had breast cancer in these 5 trials. And in all of these trials but one, they showed that there was protection from premature ovarian insufficiency. Very encouraging. I was excited when I read this. But for some reason which are unknown to us, when the same trial was conducted in patients with lymphoma, Hodgkin and non-Hodgkin, they could not find protective effect in this subset of patients, although there was always a trend towards less ovarian insufficiency, but a clear-cut significant protection was not there. Makes all of us think, what is the reason, possible reason in lymphoma patient? We always say that, hematological malignancies are liquid malignancies, so they may have, impact which are far and wide in reach than solid tumors. So can there be a direct effect on gonadal function? We have evidence for it, so there may be a direct effect. Or is the kinetics of GnRH agonism different in patients who are having hematological malignancies? Is something only further research can answer. Slightly disheartening, but these papers are also slightly older, 87, 7, 10, 13. So there may be a point in case to have a very good trial with newer agents that we have for GnRH agonist, and let us see. This is going to, because if any drug is so effective, if you see it is effective in all the trials for breast cancer, the reasons should not be many which can explain this no protection for all trials in lymphoma, especially Hodgkin lymphoma. So with this, I move on to keep, I think I'm on time. So skeletal growth and bone density from the gonadal function making a shift. Now, there are 2 types of manifestation. Number 1 is in pediatric and adolescent age group, we have altered skeletal growth. However, the bone effect in adult population, they mainly manifest as either as low bone mineral density or premature osteoporosis. These 2 are very, very different kind of manifestations, and they have different issues. Now, in pediatric and adolescent age group, like if the patient is undergoing BMT, they received either high-dose chemotherapy or TBI, it will have impact on all growing bone and plate. So therefore, there will be overall stenting, and there will be a generalized altered bone metabolism. Short stature is a known thing after this kind of therapy, especially with a full dose TBI. The second aspect in cancer-related bone dysfunction is malignant infiltration of the bone, say direct infiltration of, say, humerus or femur, or involvement of the bone growth plate metaphysis into the RT field. So both of will lead to limb length discrepancy, because only one particular bone will be shortened. And then if the treatment has led to growth hormone dysfunction because of hypothalamic pituitary dysfunction, there will be a generalized endocrinology-based short stature. Now, if we see in adult population, which is the majority of our population that we treat, the manifestation will be, again, low BMD. The patient who have received high-dose chemotherapy, high-dose methotrexate, high-dose ifosfamide, cyclophosphamide, they will be at risk. And BMT, any BMT transplant, they are at high risk of developing low BMT. What are the other risk factors? We have to be very, very careful in patient, say autoimmune hemolytic anemia. It's not a cancer, but if somebody is on prolonged glucocorticoid, they are at risk. The patient who have sex hormone and growth hormone deficiency, as I discussed, they are at risk. The patient, I think after say the diagnosis of cancer, they may become more sedentary. Their nutrition might be suboptimal. So these patients are at risk of having adverse skeletal late effects. How to screen for them? Luckily, we have a very simple non-invasive tool called DEXA scan, which is dual energy X-ray absorptiometry. And so if you do it, you find it normal, then the recommendation is you repeat it 3 yearly and keep following. But if there is any defect in DEXA, then you have to probably repeat it annually. There is controversy regarding at what level you have to intervene, what drugs can be given. It is not yet very much decided unless it is osteoporosis. Osteoporosis, then you have to be in consultation with the orthopedician, treat it. But otherwise, just alteration in DEXA values, BMD values, T and Z score, still the controversy remains. What can be done? The simplest things are always free. You can advise weight-bearing exercises, calcium and vitamin D supplementation. Now, bisphosphonates, again, they are controversial, but then because we have huge experience with them in treating multiple myeloma and we know how to handle them, probably annual dose can be given if there is a low BMD, but it has to be done in consultation with experts in the bone metabolism. If there is a peculiar case who has sex and gonadal hormone, then the replacement of therapy is the treatment for adult patients. Moving on to this very new part of late effect, which is chemotherapy brain. Now, chemotherapy brain is a colloquial term. It is not a medical term, and it is defined as, it is used for cancer survivor to describe thinking and memory problem that can occur during and after cancer treatment. I think all of us have seen patient come to us. They say, "Doctor, हम भूल जाते हैं या हमें याद नहीं रहता, medicine लेना भूल जाते हैं." So this is very common, and we always, because we have so much more to look after, we just tend to sideline this. The technical term for chemotherapy brain is CICI, which is chemotherapy-induced cognitive impairment. The presentation, common one: confusion, mental fogginess, difficulty in finding right words, learning new skills, attention span gets shortened, patient takes longer time to complete a simple task, they have verbal memory issues and visual memories issues. Very common and very non-specific features, but then we will pick up them if we look for them. So therefore, my task is to sensitize the other fellows, colleagues who are part of this webinar, that these are not simple fatigue or a general aging issue. This can be the impact of chemotherapy brain. Right. So chemotherapy brain, it is reported in as high as 35% survivors, meaning thereby every one patient out of 3 survivors that you see in your clinic might have chemotherapy brain. Now, it can be multifactorial, and the postulated mechanism is impact of chemotherapy, radiation to brain, and as much as anesthesia during surgery for cancer given to a patient can also be a part of this post-survivorship chemotherapy brain. Risk factors are chemotherapy brain are advanced age. Somebody who is at the advanced stage is definitely comorbidities, dyslipidemia, vascular disease, and genetic factors. Now, I would like to draw your attention on primary CNS lymphoma. If you read the paper by Lisa De Angelis, they clearly say the patient younger than 60 years, you give consolidation radiotherapy. If the patient is more than 60, you do not give, just give chemotherapy and leave it. The reason is because after age of 60 years, the cognitive decline because of high dose radiation was precipitous. So although patient might remain alive, but they were almost in dementia, accelerated dementia. So therefore, that is the reason that advanced age is the biggest risk factor for chemotherapy brain or cognitive impairment. Mechanism is here, like we have seen for cardiotoxicity. It is the same mechanism as we see for cardiotoxicity. Reactive oxygen species, it goes in the brain, produces DNA damage, lead to apoptosis, and there is a shrinkage, which is dementia. The additional mechanism of chemo brain is pro-inflammatory cytokines. These cytokines cross the blood-brain barrier, attack on hippocampus, which is kind of our emotional powerhouse, and ultimately they have this neurodegeneration effect, and ultimately collectively they lead to chemotherapy brain. Now, when the research was undergoing and people found this aspect, they thought of antidepressant, because antidepressant can produce exactly these kind of symptoms. They can chelate, some kind of free radical. they can have impact on neuropathy, they can have impact on expression of various cytokines. So I think there is a biological reason for us to think that antidepressant might be useful. They can be useful because they can do neurotransmitter modulation, they can inhibit progressive neuroinflammation and neurotoxicity, and they can help in improve long-term neurogenesis, which is actually needed. So should we start antidepressant? The answer is we are not there yet. We have to cross the bridge when we reach there. So definitely a biological plausibility is there, but sufficient clinical evidence is not there that, tomorrow if there is a patient or with, forgetfulness, we start on antidepressant. No. What is needed? Definitely a well-designed prospective clinical trial. Anybody who's interested, I think we all can in India collaborate for these kind of trials, because all antidepressants are very easily available and they are approved. So doing such kind of trial be a very, very important contribution from this part of the world. Right. I think now I am at the last topic of today's talk of mine, which is second primary neoplasm. I have kept it in the last because it is the most dreaded complication of any cancer therapy. Let us see a few key points about second primary neoplasm. Number one, we will call them second primary when they are cancers. They're caused by the treatment of previous cancer, which can be either radiotherapy or chemotherapy. They must be unrelated to the first cancer that was treated. That is very important. And the latency can be as short as few months to as long as many decades. So they can happen anytime. We have to be watchful and suspect for it. Now, there are only two important factors which can predispose a patient for second malignancy. Number one, DNA damaging potential of anti-cancer therapy, which we know there are only three agents which can produce DNA damage. Number one, most strong is radiotherapy. Number two is alkylator. And number three is topoisomerase inhibitors. These are the three main agents. And the longevity after treatment of primary cancer, it is linearly related. The longer a patient lives, the higher the chances of developing a second primary. So these are only two factors. Now, this a very, very important plot. In this, you can see various, almost all medical oncology is depicted here. All types of cancers are here. Here we have number of patients who develop therapy-related myeloid neoplasm. Now we are talking from secondary cancer, we are talking of therapy-related myeloid neoplasm. And here we are talking of standardized incidence rate of these myeloid neoplasm, which is secondary AML. So you see the patient who received breast cancer, NHL, to some extent patient myeloma because they received lenalidomide, and lung cancer also, they have relatively higher incidence of secondary AML. But if you see the ratio was maximum for patient with sarcoma, because bone sarcoma reduce adriamycin, which is doxorubicin. Hodgkin lymphoma, they also receive procarbazine and doxorubicin, and sarcoma again. So therefore, the ratio, which is like ratio between incidence of AML, therapy-related AML in these patients, and incidence of AML in the age-matched other people. So therefore, these diseases are of younger age. The incidence of AML is very, very low. So whatever AML they have therapy-related, their ratio becomes very high. So this is likely to make understand this important graph. All other solid tumor, thankfully, are on this side of the curve, except these two, three. So if in our follow-up, if we talk of hematology, Hodgkin lymphoma, multiple myeloma, and non-Hodgkin lymphoma, all three have high risk of development of secondary myeloid neoplasm, mainly MDS AML. Now, for fellows who are listening to this talk, it is very important to see the characteristics of therapy-related AML MDS. And we have two types of therapy-related AML MDS, two major classes. Number one, those produced by alkylating agents. Number two, those produced by topoisomerase 2 inhibitor. Topoisomerase 2 have drugs like all our anthracycline, apirubicin, doxorubicin, daunorubicin. Then we have etoposide, taniposide. They are topo inhibitors. So the first difference is latency. Alkylator takes longer time, 5 to 7 years, maybe 10 years, to produce a secondary neoplasm myeloid one, while the latency between topoisomerase 2 inhibitor is very short, 2 to 3 years only. The second thing is, majority of the patient which have therapy-related AML will be secondary to alkylators in comparison to topoisomerase 2. Ratio is 70:30. The cytogenetic characteristic is deletion 5q and 7q abnormalities associated with the alkylator agent. Now we all get done cytogenetics routinely for AML, so it is very easy to get. And translocation related to 11 and 21q is associated with topo2 inhibitors. This is the long list which I just spoke about. Anybody can go through this. One more important point is that alkylator related AML is usually preceded by MDS kind of situation, therapy related MDS to AML sequence. On the other hand, topo2 inhibitor, they come with a bang. I recently treated, our team at PGI recently treated one child who had Ewing sarcoma. After Ewing sarcoma, she receives lots of etoposide, and within 2 years, she presented just with a full-blown AML, no myelodysplasia, no cytopenia, did not give a chance. We did transplant her, but could not save after very, very aggressive kind of malignancies these are. We should just pray that patient should not have them. Now, before I conclude, couple of points regarding Hodgkin lymphoma, because most of these patients are young and they live a long life. And just by the virtue of living a long life ahead of them, they are at higher risk of developing secondary neoplasm. Now, this is data from 1,000 lymphoma patient, and what they reported, Hodgkin lymphoma patient, that if Hodgkin is successfully treated, then these patients will have 6-fold increased risk of dying from a secondary cancer. So 6-fold is not the risk of having a cancer, second cancer, but death of second cancer, which is very high. And if these patients receive chemotherapy before they were 21 years of age, the risk was even greater, up to 14-fold. So there is a considerable risk of death from secondary cancer, and therefore we have to be at a lookout for secondary cancer in our survivors of Hodgkin lymphoma. And the kind of malignancies in order of their incidences, the commonest malignancy in Hodgkin patient is breast cancer, thyroid, bone, colorectal, lung, and stomach. They are in order of their incidence. And I think many in this group would know that there is a very prolific lymphoma researcher who is from India. And she had Hodgkin lymphoma treated initially, developed secondary breast cancer, and thankfully she has successfully conquered both and is doing very well. So these are the common one. Why breast and thyroid? Because breast and thyroid cancer, secondary cancer that we are seeing today, are the result of therapy given in late 90s. At that time, radiation doses and field were more broad and liberal. So these are radiation-related secondary cancer that we are seeing in Hodgkin patient, and other are also at higher intensity. This is the data just for sake of statistics. So in Hodgkin lymphoma, at 10-year survival, the risk of a secondary neoplasm is around 4%. By 15 years, it doubles to 7.4%. Thankfully, for some reason, for non-Hodgkin lymphoma, the risk of secondary neoplasm is less than Hodgkin, which is only 2.75. For multiple myeloma, the 10-year risk is around 6%. And for ALL, I'm very, very pleased because of better techniques and in radiotherapy, reducing the dose of radiotherapy, there is no additional risk of secondary neoplasm. And this is from data from a paper by Dr. Pui, who does a lot of pediatric ALL. This is pediatric data. So before I conclude, this is a model of second malignancies, and this is given in terms of multiple myeloma, but it is true for any malignancy. Number one, any patient who is having, here it is myeloma, but you can take any malignancy. Number one is therapy-related impact. We all know about it. Then primary disease, in this case myeloma, has also genetic aberration, which may predispose a patient for a secondary malignancy. Then host genetic factor, like we know familial cancer syndromes are there, where a person can have multiple cancers, environmental factors, and behavioral factors. So all of these, actually, this is the model of development of second malignancies in any tumor. Here it is depicted for multiple myeloma. So now with this, I will conclude, and I will conclude with proposal of 3 models of cancer survivorship, and we will discuss their feasibility after the presentation. The first model is integrative care model. In this model, the proposal is that survivorship care team and prevention team should be a part of main oncology hematology team. I mean, so it has to be a part of one team. It ensures early transition of a patient after cancer treatment is over. There is no need of referral because survivorship team is already a part of the treating team. No need to referral. They are constantly monitoring the doses of chemotherapy given in a patient. Early features, maybe doing troponin very early, having hormonal function very early. So it is integrated model. The main problem is it is a dream model. It does not exist. I'm sure there are few survivorship clinic coming in the West where they might have it, but otherwise availability is a big issue. And then if you have so many experts in one team, the cost is going to be prohibitive. The second model which can be ideal model is multidisciplinary clinic care model. This is now coming up in a big way in the Western countries. The silver tsunami I spoke of in the beginning. What they have done, they have opened a dedicated cancer survivorship clinic. We have dermatology clinic, endo clinic, neuro clinic. Now they have survivorship clinic where the treating hematologist, oncologist, they treat. After the treatment is complete, they refer the patient to the survivorship clinic, which is all together. And there they may have a cardiologist and endocrinologist all together. Again, in our country, such availability is unheard of. It is going to be costly. So many experts bringing at one place is costly. And this needs an additional referral. And you know what happens most of the time? Patient develop emotional connect with a primary physician. So to get survivorship care from elsewhere may be a cultural issue. So this is one thing. And the last thing is a consultative care model. I think this is what we can practice more often, which is like a primary hematologist, oncologist, or a primary care physician, MD physician in the hometown. They do basic screening and management of late effect. They keep doing screening, early management, like giving ACE inhibitor, giving some calcium, vitamin D and all. They can do it. And then they refer to the respective experts on need base or periodic basis. This we can develop and decide when should we refer it to an endo person or a gynecologist or so on. It is a collective care. It is much more feasible, cost effective also. So I think this model, which is a more practical model of survivorship care, is going to be the way forward in our country, while Western countries have already opened up a dedicated care. The resources I would recommend if fellows are here, there are two very excellent guidelines. One is Children's Oncology Group, which they have a very nice guideline on long-term follow-up, freely available from their website. The second is NCCN guideline. They have a separate survivorship guideline. This is the latest version. And if you see the late effect, they have given detailed report on how to manage cardiovascular issues, then particularly anthracycline related issues, then anxiety, depression, trauma, distress, cognitive, which is chemotherapy, brain, general fatigue, lymphedema for breast cancer patient, cancer pain, hormone related sexual dysfunction, sleep disorder, and then employment, return to work, vocational, all those aspects, they are part of NCCN guidelines. It is a very, very good resource. Reading all of these, it just made me think that it takes a village. It takes a village to raise a child. It takes even a larger village to treat a cancer. And with this, I'll just quote Helen Keller, that alone we can do so little, but together we can do so much. And I thank Sir again for this excellent opportunity to touch upon this topic, which is close to my heart and everyone might have benefited. Thank you.
Thank you, Dr. Gaurav. That was wonderful. A lot of hard work, and you put across in these 45 minutes so much of information. And it was so important because it's not something we discuss every day. And many, especially the junior, who are going to start their career, will benefit from, and ultimately the patient will benefit. So we'll give you rest for 5 minutes, and then we come back with a question and answer session to you. In these 5 minutes, we'll utilize the timing to show you the result of the quiz that we had asked you. I'll share my screen again. So we come to the Sunday quiz that was put to you. This quiz was related to systemic AL amyloidosis. You were given 9 statements. One of the statement was false, and you were asked to pick up the false statement. And these were the 9 statements. A correct and early diagnosis of amyloidosis is an unmet medical need. This is a correct statement. Not only in the developing world, even in the best of the centers in the world, the clinical features of amyloidosis, because it's very different from myeloma, are not picked up by a consultant physician, because it damages the kidney, damages the heart, damages the GI tract, damages the liver, damages the peripheral nerves, and you've got many conditions which do that more commonly. If there was a simple way to assess for amyloidosis, probably this unmet need would have been fulfilled, and maybe serum-free light chain assay being more liberally asked is one step in this direction. Alkylating agent, autologous transplant, and bortezomib were three welcome giant leaps in the treatment is a true statement. Long ago, the alkylating agents came with the first treatment for the AL amyloidosis, and then the transplant, and then recently bortezomib. To this list gets daratumumab, and therefore this is also a correct statement. Dara, now we have enough data to show that it is extremely useful for relapse setting as well as newly diagnosed patient, and it's called the fourth giant leap. Fourth is also a correct statement, mentioning that 11-14 translocation accounts for 40% of patients of AL amyloidosis. Large number of people have answered this as a wrong statement, but this is a correct statement. So when you have a patient of AL amyloidosis, always look out for this translocation. Of course, for this, you have to do the bone marrow. The deep responses can be achieved in 70% of this group with venetoclax-based therapy, and therefore it becomes very important. This is also a correct statement, and therefore it becomes extremely important that you look out for this. Though venetoclax at the moment is not used as the first-line treatment for amyloidosis, but being a non-curable disease, you will require this. And 7 out of 10 patients responding, if they've got this translocation, you must search for this. This is even more important than myeloma. And then comes this master trial, which established the use of daratumumab. The Andromeda, which was the pivotal phase 3 trial, where Dara with VCD was compared against VCD to show the advantage of Dara. So this is also a correct statement. And 3 predictors were shown to have negative outcome, and this is also a correct statement. If your anti-pro-BNP is very high, so advanced cardiac patients do not benefit so much from Dara. If there is 1Q21 gain, they also do not benefit that from Dara. And if you have used Dara for a short period. So these are negative predictors of the outcome. So this is also a correct statement. In patients with nephrotic syndrome, there is urinary loss of Dara, and that compromises the responses. This was also picked up as a wrong statement by many those who have replied, but this is a correct statement. The patients having nephrotic syndrome, they lose Dara, the blood levels were low, and their outcome was not so good as the rest. Dara-based treatment is effective in removing deposited amyloid fibril from the target organs. I mean, a student of amyloidosis will know that we are not yet successful in removing deposited amyloid fibril from the target organs. This is another unmet need, actually. So this is the false statement, number 9. And these are 2 major unmet needs. Suspecting AL amyloidosis early, more liberally looking for it by lab investigations, and diagnosing it early before the heart is damaged. And the second one is to develop an agent which can remove the deposited amyloid fibrils. Now, this slide gives you the development of treatment of AL amyloidosis from 1990s to 2022. Slowly, the 2 to 3 year mortality rate, which was 80%, has come down to 50%. And slowly, the overall hematological response, which was 50%, has gone to 80%. Now, if you look at the achievements, melphalan, prednisolone, autologous transplant, use of dexamethasone in place of prednisolone, and then melphalan with dexamethasone. And then came an era where the IMiDs were used, Theridex, Lendex, CTDex, and then came this master, the PI, and Cybol-D. So from melphalan to autologous to Cybol-D was the 3rd major step, and then the 4th step is daratumumab. And then others are under research. And this is the overall survival, which is shown in red, and complete remission rates, which are shown in blue, using Dara-based therapy in AL amyloidosis. So whether you have previously untreated, newly diagnosed patient, or you have relapsed refractory patients, and then the aggregate of all the studies. So if you see over here, you can achieve 85% of overall response and approximately 40% of complete response in patients of relapsed refractory amyloidosis using Dara-based therapy. And this is for newly diagnosed. Responses up to 90%, complete responses up to 60%. So the last statement was the false statement. The answer expected was 9. And we don't have correct answer. We just have the fastest finger first. Just one single correct answer we have. and that is Dr. Urmi Mala Bhattacharya. She is MBBS MD Internal Medicine, DM Fellow Clinical Hematology at PGI Chandigarh, from the institute where our guest speaker was today. So congratulations to you. And that's all for the day. And I'm not sure whether she has joined this side. I requested her to join to congratulate her directly, but I don't see her. She has joined. So anyway, thank you very much and congratulations to you. And Dr. Gaurav, it's from your institute. And we come back to you for the QA session. Dr. Gaurav, you can open your video. Right. So now we will go to the question and answer session on the presentation of Dr. Gaurav. We will be using raise hand sign. So those of you who have a question can start raising hand and we will go in the order. Meanwhile, I can ask you a question from the chat box. Question from Dr. Malini is, there are any way to prevent cardiotoxicity from cyclophosphamide in the doses used for haplotransplant?
Actually in truly high doses, unfortunately for cyclophosphamide, we do not have any direct antidote for that, like the way for we have doxorubicin. The only way to give is hydration and probably slowing down the infusion time. Usually endoxan is traditionally given over 30 minutes to 60 minutes infusion. So probably that may help, but if you reduce the infusion time significantly, the myelotoxicity is going to be profound. So it is like give and take. So therefore, that is one way you can reduce it, but high dose is something you have to live by.
Okay. So we have Dr. Priyanka asking you a question.
Sir.
Yeah, please go ahead.
So my question is that, so you presented two slides, one about the breast cancer and another about the hematological malignancy, about the protective effect. Are you routinely using this because there is still not clear data?
Yes. So, yeah, definitely. If is a patient-centric, let me tell you, if there is a young woman who is coming and almost marriageable age, and we discuss with them, and I'm using it. The thing is that subset is not going to be very large. So a young, say, Hodgkin lymphoma patient having 1 or 2 children, then probably we will be discussing that aspect more. So I am using them, and the results will be only known later, whether if they have good menstrual function, but fertility and all, only time will tell. So this is very easily doable because, as you know, I'm also a medical oncologist, so I treat some prostate cancer. My main is hemat-oncology only, so we give that. So it's very we are trained in giving that. So, and it's not very difficult. Anterior abdominal wall, it looks very ominous, a very big syringe because it is a implant, very thick gelatinous implant which goes inside. So, but we can do it.
So can I ask another question?
Of course.
Yeah. So, sir, do you see a late side effect as a permanent hair loss? Because means physical appearance is also very important for these kids who are in adolescent age group, and when they go to college and they have these issues of hair loss. So do you see that frequently, and do you recommend using a cooling cap while patients are receiving chemotherapy?
So in the late effect, there were cosmetic issues like pigmentation and hair loss. They are part of it, but then since we have to keep the focus in a stipulated time, otherwise the late issue can be a topic in itself. Each side can be a topic. The answer is permanent alopecia is very rare with chemotherapy. What happens because of injury to the hair follicle, there happens distortion of the hair, and therefore the hair growth may not be as fast. The patient may have a wrinkled hair, but it is never permanent. Yes, if somebody is having androgenic alopecia already, say somebody 50, 60-year-old male, and having, so they may have acceleration of the androgenic alopecia, number one. The second part was cooling cap. The answer is that there are studies in use of cooling cap in breast cancer patients. I will tell you the benefit and pitfall both. The benefit is because you do a cryo application on the hair follicle, there is an instant vasospasm. So chemotherapy does not reach the follicle. But people are saying that in some series, incidence of cutaneous metastasis theoretically can rise because that area remains shielded from the benefit of chemotherapy. So this is, something which we have to be pragmatic about. But in breast cancer, the positive data is there. It is being used.
Thank you.
But early non-advanced lymphoma, some young patient, probably there should be a space for using cryotherapy. And I can tell you now cost also. The running cost of, I recently interacted with one provider of this cryotherapy. In a public sector, not for profit, running cost can be as low as 1,500 per dose cycle. So whether hospital bears it or the patient, that is depending upon the model of healthcare delivery.
Thank you, sir.
Thank you, Dr. Priyanka. One more question from the audience. What is the method you use to prevent gonadal toxicity in young girls?
As I told, if the patient is agreeing on GnRH agonist, that is what we use. And that's pretty much what we use, because there are not many options to reduce gonadal toxicity. The second thing is we try to avoid radiotherapy in the pelvic area if possible. So say if we are at the borderline of deciding to give radio or to not to give radiotherapy, then probably in a young patient who has fertility issue, we probably will err on the sides of not giving after a detailed discussion.
Thank you. Dr. Abhilasha, your question.
Very nice, sir. You have touched upon the cardiac late effects of newer targeted therapies. Now, what are the other long-term effects like viral reactivation and effect on immunity or other systems?
Yeah. So definitely, late effects are usually seen in patients. Viral infection-related late effects are seen in patients who are receiving long-term immunosuppressions, like solid organ transplant recipients, like hematopoietic transplant recipient on GVHD. But if after say within 1 year, 1 to 2 years, if we speak of immune reconstitution, the humoral immunity is reconstituted within 2 to 3 months, and the cellular immunity is reconstituted within a year. So if somebody has crossed that period and after that they are doing well, then the infection-related late effects are not very commonly seen except splenectomy. However, I would like to touch upon that we have to be more, a very important aspect of survivorship is immunization. I did not discuss because it is a separate topic altogether. All patients who have received stem cell transplant, whether allogenic or autologous, they need to undergo a battery of immunization schedule. There are schedules and every center can develop their own.
Thank you.
Thank you, Dr. Abhilasha. One more question from the audience. There are two questions related to heart. One is, what is the long-term outcome of idiosyncratic toxicity of adriamycin on the heart? And second is there a protocol to follow up the cardiac toxicity?
Right. So idiosyncratic, thankfully, they are far and few in between. So we do not have data as far as the long-term outcome. Maybe there may be some rare data, we need to find it. If it is flash pulmonary edema, it is, many times can be lethal also. Arrhythmia, once you take the drug off, they usually do not recur. But if you are asking for a categorical data, that I am not aware of. And the mechanism of follow-up of cardiac dysfunction is at our center, we recently did a thesis in which we did GLS. But since it was a part of thesis, somebody was doing detailed echo at regular intervals. So I would recommend that if you are at a center where good echo machines and cardiologists are willing to do GLS, it can pick up cardiotoxicity early. Otherwise, if you do only conventional echo and they will give you ejection fraction low, by that time the toxicity has already advanced. So you will pick up at that point in time. So GLS is something which is non-invasive. Only when you have to put a probe over a patient like echo and you will know it. There is another method which is like this is a research, maybe we can talk separately. We recently conducted seeing the PET-based activity. We see the myocardial uptake in PET-CT, which is anyway done for lymphoma assessment. And we try to see whether an injured myocardium is picking up more FDG because it is metabolically more active. So that is a research part which we are trying to study. And if something comes out, we will be very happy to share.
Thank you. Dr. Ganji, your question.
Yeah, thank you, Dr. Gaurav Prakash, for such a great lecture. I have a question for you. I have recently seen a patient who is 8 months ANC, and now I have to counsel this patient for chemotherapy as well as to talk about what is going to happen to the child who is going to take birth and then grow in passage of time. So how are you going to counsel this patient as regards to chemotherapy, and the treatment-related effects to the growing child later on?
So the patient is 8 months pregnant and no therapy is given as yet.
Yeah.
And what is the primary?
Acute myeloid leukemia.
AML. Okay.
Yeah.
So for AML, I think our approach at PGI is more aggressive. 8 months is actually very, very border. It's a very tough zone. So now by 32 weeks, the pulmonary maturity, what our neonatologists tell us, that pulmonary maturity is there. You induce immediately and probably can wait 1 week, and surfactant is easily available. And then you start therapy. If it is 8 weeks complete, 32 weeks are done, 8 months are done. 8 weeks or 8 months?
8 months. 8 months I'm talking about.
Okay. So then I think there is no doubt then. At our center, how we would do, we would induce the labor, deliver the baby, if needed, the NICU care and all given, and immediately once we have postpartum area things handled, we induce the patient with the AML full. No breastfeeding, and patient goes on, the child baby goes on the formula feeding, suppression of breast feeding to the mother, and full chemotherapy.
Thank you.
Dr. Ganju, one more question from the audience. And this is related to, is there a difference in the treatment of chemo-related MDS from de novo MDS?
Yes. So the thing is that our threshold for a definitive transplant will be higher in chemotherapy-related myeloid neoplasm because they are the defect is at a stem cell level, and just by chemotherapy we can just control it. They are very aggressive neoplasm. So once you bring the disease under control, you should take up the patient for a definitive allogenic transplant, sibling match, haplo, or unrelated, depending on the availability of the match. There is no doubt.
Thank you. Dr. Aditya, your question. Dr. Aditya Barteke.
Gaurav, you mentioned about how to actually implement this in your practice. So what we see in our practice sometimes, there is a subset of patients who are reluctant to come for follow-ups later on once they are cured. So maybe then we are losing on opportunity to screen them for late effects. So how do we handle this problem?
Yeah, Dr. Aditya, I think I completely share your anguish on this because two aspects. Number one, patient find it difficult to come, and all of us, the clinicians, may find it difficult to accommodate if they come on the prescribed recommended follow-up schedule, because in public sector hospital, especially ours, is a extremely overloaded practice. Most of us have, doesn't matter which sector it is. So I think this is something where this will only improve when we have a clear-cut survivorship plan, teams, who are working on this. Short of it, if you expect the only treating physician to be responsible for, say, cancer screening also, then optimal timely treatment, and then survivorship care also, and along with teaching and researching, so it is going to be too much. Jack of all trades is not going to work. It will only improve once we have a dedicated clinic. Like we have now BMT survivorship clinic, because BMT is a very, very well-defined kind of therapy, but chemotherapy is protean. So that is the answer. Short of it, if you have interest like I have, so you can start to develop a clinic for this, and that is the only way.
Thank you.
Thank you, Dr. Aditya. Next question from the audience is related to, is there any data, international or national, on the effect of psychoactive drugs on CICI? Is the Indian Medical Oncology Group considering this?
Okay, so I showed you data on antidepressant, but then if you're asking for a clinical randomized data, I could not find it. I will not say there is none, because I tried to look for it, but there was no robust data regarding this. Your suggestion is very welcome. The Indian oncology, hematology community should consider two things. Number one, cardiac for our ACE inhibitor, statins, and antidepressant for CICI. These two areas, the research, clinical research, very simple with minimal inputs can be done. We all have our survivors database is there. We just need to put our act together and come to, start working on it. Most welcome.
Thank you. Dr. Avariti Baveja, your question.
Thanks a lot for such an enlightened talk, sir. Sir, since HMA and venetoclax are being increasingly used in AML patients, sir, what is your experience regarding cardiac toxicities with use of venetoclax?
Yeah, so we have not come across any particular cardiotoxicity with venetoclax, and the reason can be two. Number one, because in a patient on AML induction, our focus is definitely more on the primary. So we were not very actively looking because traditionally it is not anthracycline. So that is the answer. And what was the second part of the question?
Sir, actually, two of my patients have experienced cardiac toxicity. There was a fall in the ejection fraction. So that is why I was like concerned.
Right. So I think you have made us, more alert to look for it. Thankfully, as of now, we have now more than 20 patients who have been treated with this combination. But we probably now we can go back and do a elective echo in them, just a simple echo in 20 patients, and we probably would know.
Thank you, sir.
Yeah, good. Thanks for sensitizing about it.
Thank you very much.
Dr. Avirati. Another question from the audience. Although not serious, yet a troublesome effect is mucositis and dry mouth following damage to the salivary glands after radiotherapy. Can this be prevented by shielding the salivary glands? Can one use pilocarpine long term?
So, of course, for the first part, definitely, of course, it is. So that is where the role of IMRT is, image modulated, intensity modulated. So when you give head and neck radiation, you modulate you reduce the intensity, which may go to the salivary gland. So that is the answer. The only thing is that access to IMRT is difficult. A conventional cobalt machine cannot deliver IMRT. You have to have, LINAC with advanced software. As far as pilocarpine is concerned, pilocarpine is not a therapy, it is symptomatic. You give it, there will be some, if for pilocarpine to be effective, there has to be some residual salivary gland. If it is a complete annihilation, then it will not be of use. So you use it, it will have some impact. So therefore, the answer is artificial saliva and modifying the lifestyle of a patient, having more frequent water sips and oral hygiene. So eating is a very small part. The biggest part which these patients miss is oral infection control, dental caries because of saliva, they prevent it. In these patients, those are the bigger issues. Eating, they can manage semi-solid food, shakes and all, they can manage, but hygiene and dental caries is a major issue.
Thank you. Dr. Muralidharan, your question.
Thank you for the opportunity, sir. My question is regarding the fertility preservation in males and females who are undergoing in transplantation or high-dose chemotherapy. We know for sperm preservation can be done in the males. How do you counsel in PGI or in any of the higher centers? Like, how do you have to counsel female survivors after post-transplantation? Thank you.
Thank you for the question. As you said, in males, it is not very difficult. I'm very glad to inform that our Department of Urology is working on a sperm preservation facility within PGI. And although it is not yet functional, so once it is functional, then I think it will be very easily accessible for our patients who are getting treatment here. For women fertility preservation, it is always a global challenge, because the oocyte harvesting as well as preservation is a technical issue, is more difficult. Oocyte needs to be induced, unlike sperms. And the second and better results are obtained with embryo preservation. But the only problem is for embryo, you have to have a partner who can give sperm. So newly married couple or maybe somebody who have a partner who can give sperm, then embryo preservation has better long-term result in comparison to only oocyte preservation. These are the two methods. Then some people do ovarian implantation near diaphragm so that pelvic radiation can be given. Say if somebody is having a large lymphoma, sacrococcygeal region, you want to radiate, then you implant the ovary elsewhere before radiotherapy. So these are 2 or 3 mechanisms for fertility.
Sir, do you routinely do LH, FSH, and AMH anti-Mullerian hormone.
So luckily we have great support of our gynae department, and there is a unit which is focusing on this fertility and onco fertility part. So for all chemotherapy-induced amenorrhea, if the patient is worrying or having those issues, we refer to them and we let them decide which part of menstrual cycle, which hormone to do. So we are completely dependent and thankful to them.
Thank you, sir.
Thank you, Dr. Muralidharan. Dr. Nishad.
Sir, that was a very informative lecture. My
you.
question is about osteonecrosis. One of my adolescent B-cell ALL patient has developed a osteonecrosis of the talus, and many people have seen him. There are reports of autologous platelets transfusions, autologous platelet treatment, bisphosphonates therapy, and then surgery. So, what do you advise for such patients, sir?
The patient ALL, so I presume it was a steroid-induced osteonecrosis, and I have never managed somebody with talus osteonecrosis, and naturally it's more common in femur and weight-bearing bone. Talus is a weight-bearing bone. So the answer is you have to work in close collaboration with your orthopedician, and the best results are with surgery and cessation of steroid if the patient is still on steroids. Bisphosphonates and others, as far as I understand, they have questionable value. Calcium supplementation can be given immediately, cessation of steroid, and surgical correction. Otherwise, what happens? Because of the weakened joint, the additional load will be on the remaining part, and that part will also become deformed as the time will progress.
And role of platelet, autologous platelet, sir, have you heard about this?
Really sorry, I have absolutely no idea about the role of activated platelet infusion locally. I have not read about it.
Thank you, sir.
Dr. Shajia, your question.
Good afternoon, everybody. So, thank you for that. It was a very beautiful lecture. And my question is rather a female AYA who had a favorable risk AML. Now she is in remission and she wants to conceive. Now, so how do you go about advising her, and how frequently will you monitor by conventional echo? And does desodoxin have any role in preventing cardiotoxicity in such patients if we think of it?
Dr. Shazia, thank you for your question. The thing is that if the patient is now cured of AML for 2 years, so if I hear it correctly, you are talking about conceiving or cardiotoxicity?
No, not conceiving. She wants to conceive now because there's a higher chance of your cardiac failure and all peripartum and postpartum in the postpartum period. So
Okay.
that's how do you tackle that? That's what I'm talking about.
Yeah. I mean, you want to be preemptive before a patient thinks of conceiving and having a child. Correct. So I think it is the same survivorship thing for any patient who has been treated with anthracycline, and you keep on following them forever because CHF can happen even 20 to 30 years after. So having an annual echocardiography is sufficient for it. Now, if you are having some difficulty, some issues in the echocardiography, then you go for a better like a Muga scan, or you go for hormonal testing like NT-proBNP is the most sensitive one for CHF, impending CHF. But just because of NT-proBNP is elevated and patient is young and want to have a family, I think it is not a reason enough. There has to be a collective discussion between obstetrician, because for them it will be high risk pregnancy, and cardiologist together. It has to be a teamwork.
Okay, thank you, sir.
Thank you, Dr. Shajia. Dr. Ganju again. Yes.
Yeah, we have been treating acute promyelocytic leukemia with atra and arsenic.
Yes, sir.
Do you have any data for long-term complications related to these two drugs?
So Abhi, recently, sir, we have published our data on atra arsenic long-term follow-up recently. I think it will be presented in this coming ASH. So, however, the focus of that paper was on outcome and toxicity and acute issues. So, as far as I am concerned, we do not have long-term survivorship data, because the point, sir, is for survivorship, you have to look into it. Unless you do, say, annual echo for 10 years, you will very rarely know that, cardiac decline is happening, unless you do the hormonal profile for endocrinology. So it has to be a structured activity. And what we have done for arsenic atra is more a clinical efficacy and clinical use data. So
thank you.
Because of
thank you.
yeah.
Thank you.
Thank you. Dr. Chirasri.
Thank you, sir, for your excellent lecture. I have a question. If a patient of ALL develop PRACE-like syndrome after post-high-dose methotrexate therapy, so what should we do in that case? For the challenge of MTX, there is any dose modification, and what about IT?
Yeah. So press is always a pressing issue. It is so many DDs are there, infection versus press versus CVT. In ALL, especially, we keep thinking about it. So I think we reviewed about this regarding one of the patients. So if the press was transient and there was no easily reversible, you can give a re-challenge. You have to speak, it can occur again, because methotrexate is very important drug. You can obviate primary radiation to the brain if you are using it. But if somebody had a severe seizures and prolonged encephalopathy, then probably we have to be on the safer side and avoid. The second thing, you can have a look at the risk of ALL. If it is a low risk pediatric ALL, then definitely their cure rates are around 90% plus. So then definitely the focus should be on reducing toxicity. So it depends on a case-to-case basis.
Okay, sir. Thank you, sir.
Thank you, Dr. Gaurav. That was the last question we had. If there is anything else, any faculty member wants to ask Dr. Gaurav? None. So in that case, I'm extremely grateful to everybody, NATCO for sponsoring this, Perfect Square for managing this, Dr. Samoon Jilani for inaugurating this, our speaker, Dr. Gaurav Prakash, for doing a wonderful job preparing this talk, delivering this talk so effectively, and taking all these question answer and answering them to the satisfaction of the audience. And lastly, the audience themselves, the faculty that was present here, and the audience from all over who have participated and made this webinar a successful one. So have a wonderful Sunday afternoon, your lunch with the family, and the rest of the day. Bye-bye. Thank you.
Bye, sir. Thank you.